So today, Rachel Harrington, who is a PhD candidate in our department and also funded by a cancer education and career development training grant, will be presenting essentially what's her first aim of her dissertation project. It's going to be essentially presenting the first aim of her dissertation project. And there's some of this is still a work in progress, so your feedback is appreciated, especially as she gets to her late in class work with respect to this aim. Without further ado, it is on to you, Rachel.
All right, thank you. Well, welcome everybody to this week's seminar. Like Todd said, he sort of stole my introduction. Today I'm presenting on the prevalence, patterns, and characteristics of multi-morbidity in the pediatric population. And this is the bulk of my aim one of my dissertation. Just a couple of acknowledgments before we get started. First, my committee members who have been a great support in putting this program together, Dr. Lee, Dr. Schumacher, Dr. Cato, and Drs. Antun and Caskey in pediatrics and internal medicine. I do have to disclose I'm funded by an NCI R25 training grant, the Cancer Education Career Development Program.
I don't think you had to disclose, but I think it does sound good.
I'll take it. It's funding, and it does influence a little bit of the focus of my research as well. The CPR for providing access to Truven Market Scan, and then I do need to provide some additional thanks to Dr. Matthew Hall in Kansas City and Dr. Andrew Smitherman at UNC Chapel Hill. Both of them provided some support in the identification algorithms that I used for my cohort. As far as agenda, it's pretty standard. I'll go through the objectives of my study, some background on pediatric chronic illness and the construct of multiple chronic conditions, the methods, results, and as Todd alluded to, some ongoing work that I'm still wrapping up, and then discussion and next steps. And caveat, some of this is work in progress. When it is, there will be a sort of a footer at the bottom of the screen, so that'll be clear. So objectives, study aims. It says aims and hypotheses. This is really intended to be a descriptive study, so there are no formal hypotheses specified. There is an implicit hypothesis when it comes to my cluster analysis that there is more than one group of kids that will come out of clustering, but there's not hypothesis testing per se. My aims are pretty straightforward, calculating the prevalence of multiple chronic conditions in a commercially insured pediatric cohort, comparing their demographic and healthcare characteristics, specifically between children with multiple chronic conditions and children with a single chronic condition, and then to describe the distribution of specific chronic illnesses among the general pediatric population and among early survivors of pediatric cancer, both by the frequency of co-occurrence of conditions and using sort of an empiric data-driven algorithm, spoiler, late-in-class analysis. I'll go into that more in a bit. Just to situate this and where it sits in my dissertation research, this is the framework that my set of studies is conducted under. It's a framework for the role of multiple chronic conditions on healthcare quality of care. So the construct of multiple chronic conditions is described on the left as a function of the number, characteristics, and interrelatedness of the comorbidities. That produces clinical complexity, which then is hypothesized to reduce received quality of care, which we pick up through quality metrics and quality measurement. And then this is, of course, potentially modified or mediated by behavioral and environmental characteristics. So I have 4 dissertation aims. This is sort of where each of them sit in regards to that framework. And today I'll specifically be focusing on aim 1, which is characterizing this construct of multiple chronic conditions among children. And then there's a little bit of aim 4 thrown in, describing their healthcare utilization and costs among this group and by the characteristics of the conditions that they have. So background, pediatric chronic illness. There's generally a sort of, people tend to characterize children as a generally healthy population, which when you compare them to adults over the age of 65, that's true. But more than 20 million kids in the US do experience a chronic illness. And over the past couple of decades, there's been a shift in concern from acute to chronic illness in childhood as the prevalence of pediatric chronic illness has increased. So one study that looked at a set of longitudinal cohorts found a 12.8% prevalence in 1994 compared to about 26, 27% in 2006, which is over a 2-fold increase. Now, this isn't just because kids are so much more sicker now. That is part of it. There is increased incidence of obesity, diabetes, things like that, but there's also increased detection. This is especially true when it comes to mental health diagnoses and sort of the medicalization of mental health among children, and increased survival for conditions that would have otherwise been fatal. One good example of this is in pediatric cancers, where a couple of decades ago, average overall survival would have been 50%, 60%. Now it's averaging 79, 80%. So why do we care about this? We care because it's kids, first of all. So chronic illness has an impact on the child, both in the immediate and long term, on their health, productivity, and quality of life. It impacts the family as far as missed work days, financial costs, reduced quality of life, and increased stress. And it has a societal impact as well. My study is in a commercially insured population, but about 40% of children are covered under public insurance. So there's a taxpayer social cost there as well. And maybe we wouldn't care if pediatric chronic care was great and all of these kids were really well taken care of, but there's some signal to say that that may not be the case. So this is coming from AHRQ's National Health Quality and Disparities Report. It's a couple of years old, but trends in more recent data are similar. And this is looking at 3 quality indicators for pediatric chronic care. One generally around potentially avoidable hospitalizations, one for asthma, and one for diabetes. The benchmark there is shown in red. That's calculated off of the top 10% of reporting states for each measure. And then the national rate is in blue. And you can see this is 150 to 230% nationally over benchmark. So there is some room for improvement here in pediatric chronic care management. So focusing in a little bit more, you have children who have chronic conditions. That's a really big group. It's a wide range of conditions. You also have this idea of medical complexity, so a higher risk, higher needs group among kids. So it's a subset of children with chronic illness who experience more complexity, either through the severity of their conditions, the need for additional support, potentially the presence of multiple conditions, and so on. And evidence suggests that this group of kids has an increased risk of adverse outcomes. So the figure on the right, my left, your right, is very similar to what you see in Medicare populations, where a very small percentage of, in this case, inpatient admissions makes up a disproportionately high percentage of the inpatient costs and inpatient mortality. And children with special healthcare needs, which is one of these definitions of pediatric complexity, have been shown to have 3 times higher healthcare spending, including 2 times higher out-of-pocket costs than those without special healthcare needs. So there is this impact on outcomes and utilization. So in my proposal, I went into this in a little bit more detail, but for the purposes of this talk, the type of medical complexity that I'm focusing on is multi-morbidity. There are different ways of defining this in the pediatric population, each with their own sort of policy and epidemiologic backgrounds, but multiple chronic conditions is a nice one to use in that it gives good comparability to the adult population. So what is it? It's 2 or more conditions lasting a year or more, requiring ongoing medical attention and or limitations to the activities of daily living. This is a standard definition that's been adopted by CMS, Department of Health and Human Services, and so on. In adults, MCC has been really well studied. It has been shown to be associated with increased cost, morbidity, and mortality, as well as reduced quality of life and at times quality of care. And it's important to note here, this isn't an additional chronic condition with the adult's diabetes. It's not their hypertension and another chronic condition. It's this construct of multi-morbidity. So just the presence of more conditions adds additional burden. The complexity of managing these individuals has been well documented. There was an Institute of Medicine report back in the early 2000s. Department of Health and Human Services published an MCC strategic framework in 2011, I think, 2010, 2011. And there have been a number of clinical publications and interventions designed in the adult population. There's been a Cochrane review of these interventions, mostly focusing on continuity of care and care management. And I guess the takeaway from this is the healthcare system has been adapting to manage MCC in adults. We have care teams. There are MCC-specific quality measures that are used for pay for performance in Medicare. There are interventions that have been designed and tested to improve coordination. this concept of disease management in context. A patient isn't their single diagnosis, they're their profile of conditions. And there's also research funding around this, quite substantial research funding through AHRQ and CMS. But the pediatric healthcare system really hasn't kept up with these advancements on the adult side. And I think this is really well characterized by a comment by Neil Halfin at UCLA, which was published in Health Affairs back in 2007. Even though the benefits of comprehensive integrated service delivery programs are well documented, the child health system continues to evolve as a patchwork of disconnected programs, policies, and funding authorities without clear accountability or performance goals. So if you think back to the framework that I presented and sort of where my dissertation is focused around pediatric multimorbidity and quality, that's what I'm interested in capturing here. Is the quality of care received by this group appropriate? Are there groups that could receive better care? Is there room for improvement? The study that I'm going through today is characterizing the population. So what do we know about MCC in kids? Some initial studies suggest that up to 12% of children, around 5.5 million nationally, may have more than one chronic condition. And there's evidence that MCC's adverse effects also occur in the pediatric population. So there's studies where more severe physical conditions were associated with higher likelihood of co-occurring mental health diagnosis. And children with MCC have been shown to be at increased risk for reduced function, emergency department visits, and hospitalizations. This is a summary of some of the key studies, the epidemiologic studies in this space, ranging from Newacek in '94 up to Clark and Patel in 2015. And you can see there's been some variance over time in how chronic conditions are measured among kids and how they're studied among kids. The prevalence estimates, if you look at the Newacek study, about 15% of kids had one chronic condition and about 5% maybe had two or more. And it was really focused on asthma, hay fever, eczema, and allergy. Clark 2015, this is probably the closest analog to the study that I'm doing. She did this in a multi-state Medicaid sample. They used a clinician-adjudicated diagnosis. One of the interesting things about this study, and what I think is a main limitation of it, is they excluded mental health conditions entirely from the calculation of chronic illness. There's some sort of policy discussion around why that might be the case, but we know that kids are being treated for mental illness, they're being diagnosed with mental conditions, but it's not included in these studies. However, what they found in the Medicaid population was 88% of kids had a single chronic condition, and about 12% had two or more. Again, primarily driven by asthma, rhinitis, obesity, and allergy. And then Patel and colleagues, I put this up here because it gives a good comparison, but they limited their study to an asthma cohort. So they looked among children with asthma, how many had additional chronic conditions. And they found about 5.6% of the asthma cohort had additional chronic conditions, including hypertension, heart conditions, and autism. However, they listed a very specific number of chronic conditions. It wasn't sort of a full set of conditions. It was more severe conditions that one might be interested in from a CDC public health perspective. So in summary, children with MCC are a generally underexplored population of relevance from both a clinical and policy perspective. The US healthcare system may not be appropriately serving kids with MCC, if you recall back to those measures of chronic care and the performance there. And a better characterization of this population is needed to facilitate additional research on their health outcomes. So that's what I'm doing. As far as methods for my study, my data source is one we're all very familiar with. It's pros as well as its cons. It's Truven Health Market Scan data. I'm using 2009 through 2014 data. It has enrollment and demographic, inpatient and outpatient, and pharmacy claims, and it covers about 10 to 12 million pediatric lives annually, so it's a very large sample set when it comes to pediatrics. My study population in particular is children between 2 and 16 years of age at the start of the index year, which I'll show on the subsequent slide how that's calculated. And they had to have one or more chronic illnesses identified during baseline according to an AHRQ classification algorithm. So it's important to keep in mind in all the comparisons that I'm making, this is a chronic illness cohort. I'm comparing those with a single condition to those with more than one and across the different profiles, but I'm not making comparisons to a quote unquote healthy pediatric population. That wasn't really the goal of the study. Exclusion criteria, less than 3 calendar years of continuous enrollment, no prescription drug benefit, or evidence of active cancer therapy within 1 year prior to their outcome year. The idea being kids who are in cancer treatment are a fundamentally different population. They're receiving care, and their interactions with the healthcare system are very different than the general pediatric population. Yes, ma'am.
I'm intrigued because you said it's not a quote healthy.
Mm-hmm.
Totally depends on the definition of healthy.
Yeah.
Like if they have acne, that's the only chronic condition. You don't think they're healthy?
So I would say that's not what primarily characterizes my cohort. As far as
answer my question, you're not allowed to change the question. It's more getting to this notion of healthy.
Yeah.
Somewhat saying most of them are healthy even if they have a disease.
That's a fair point. And the idea of what is disease, what is diagnosis, what is illness in this population is maybe we shouldn't over characterize that. But they have at least been diagnosed with a chronic condition, according to the entry criteria.
Acne is considered chronic? I don't know, but I'm just kind of throwing it out because, again, I'm hearing they're not healthy. I think most of we might think they're healthy even if they have certain diseases. So I just wanted to know your thoughts.
Yeah, and maybe we can come.
I think acne for children might be considered chronic.
Yeah. It might be when we come back later in the slides to the distribution of chronic conditions, that might help clarify sort of what is driving this cohort. But I take the point that, healthy, the child's experience of healthiness versus they've got a chronic condition diagnosis that flags them for cohort entry might be different. So as far as my study design, it's a retrospective cohort study of commercially insured children. The way that I set it up, they have 3 years of continuous enrollment. The first 2 years are their sort of baseline cohort identification period where they're allowed to accrue their chronic illness diagnoses. And then outcomes, so utilization, quality measures, things like that, are measured in the 3rd year of continuous enrollment. This was structured around calendar time because that's how a lot of quality measures set it up, is from the start of the year to the end of the year. And as far as why 24 months, it's a balance. There's literature out there suggesting the more baseline time you give, the more chronic illness you detect, but requiring more than 3 years of continuous enrollment and data is a little tricky. So there is sensitivity analysis around shortening this time and expanding this time, but the primary analysis uses the 3 year. As far as variables of interest, I have sort of 2 ways I'm defining exposure in this population. Multiple chronic conditions versus a single chronic condition. And then I'm also using chronic condition clusters, so a categorical variable based on the profile of conditions that they have. Descriptive variables, demographics, it says access to care. These are more proxies of access than actual access. And then measures of healthcare utilization around continuity of care, prescription medication use, number and type of encounters, cost of paid claims, and the distribution of provider types that the children are seeing. Now, as far as the definition of multiple chronic conditions, I do want to take a minute to walk through this because I think it's important to understand how they're being flagged for entry and how chronic illness is being defined. So first, we looked at their ICD-9 codes, 2 outpatient, 1 inpatient over that 2-year baseline period, pulled all of their ICD-9 codes out. Then there's a set of classification algorithms out there that AHRQ publishes, the clinical classification software, which takes ICD-9 codes and groups them into sort of clinical conditions or syndromes. It's probably not the right word, but it groups the ICD-9s together. And then there's the chronic condition indicator, which goes through those same ICD-9 codes and flags if they are expected to be a chronic condition or an acute condition. These algorithms were generated through a mixture of synthesizing the epidemiologic evidence, expert consensus review, things like that. AHRQ does update them on an annual basis. Now, what's important for the pediatric population is that these algorithms were not developed in the pediatric population. They were developed in an adult population. Luckily, Barry and colleagues, Matt Hall, who I acknowledged at the beginning of the presentation, worked on this paper as well, actually did a pediatric modification of the AHRQ CCS-CCI algorithm over the past year. So they're working as part of the Children's Hospital Association, and they use this to look at pediatric chronic illness in the inpatient setting, but their adaptation was just generally for pediatric chronic illness. So they have pediatricians, epidemiologists, and statisticians review the code sets, whether it was defined as chronic or not, and then sort of match that up with pediatric knowledge. The idea being that some things that are chronic in adults are acute in kids, some things that are acute in kids are chronic in adults. So we went through this process, got all of their indicators in place, and then it was pretty simple. If they had 2 or more, they went into the MCC cohort. If they had a single chronic condition, they went into the SCC cohort. And a similar approach has been used in other studies, primarily in adults, but also, for example, with Barry and colleagues in kids. Analytic methods, descriptive statistics, categorical variables or proportions compared using chi-square, continuous variables were mean and standard deviation using t-test or Mann-Whitney if it was a skewed variable. Our clustering methodology was latent class analysis. This is a maximum likelihood-based method that leverages the relationships in the data to identify membership in a latent variable or unmeasured variable, which in this case we're conceptualizing that as multi-morbidity class. And what it does is it assigns each child to a mutually exclusive group of the class that they best fit on based on their profile of chronic conditions that they have in the data. As far as model selection, we use 2 different ways of looking at indicator variables. So if you think of this, you have the child and you have a string of indicator variables, 1 or 0 for the different chronic conditions that they have in the data. We examined looking at any chronic condition that had a greater than or equal to 1% prevalence and any chronic condition with a greater than or equal to 2% prevalence. Then a series of models were estimated from 1 class up to, I think we stopped at 8 classes is when the data started getting a little bit too sparse to keep running the algorithm. And models are selected on a bootstrap likelihood ratio test and Bayesian information criteria. This is still a bit of a works in progress. I still need to discuss the final model selection with my committee, but the idea is that there's also going to be sort of a face validity interpretability assessment from a clinical perspective as well. And I can say from what we're seeing that it does seem to pass muster, but obviously we want Dr. Antun and Dr. Kasky to look at it as well. So results. Final cohort is very big. So there are about 25 million children identified in Truven, unique children identified in Truven between 2009 and 2012. After applying the age restriction and the continuous enrollment restriction, I go down to about 6.2 million. So you can see continuous enrollment does have a big impact on the criteria here. Excluding for no eligible chronic diagnosis or evidence of active cancer therapy, I ended up with a final analytic cohort of about 1.5 million kids. About 1 million of them had a single chronic condition on file, and about 550,000 had 2 or more on file. And then of interest for my cancer cohort sub-analysis, about 5,000 of these kids were identified as being pediatric cancer survivors, so out of active therapy, and then split in the number of chronic conditions that they had. Demographics at baseline, there weren't really many differences between the SCC and MCC group. I will put this caveat out here now and it comes back again later. P-values in this population are pretty much meaningless for interpretation. Everything's statistically significant because it's such a large sample size. That's why on a lot of these you'll see standardized differences presented next to them to try and give you an idea of the magnitude of difference between the SCC and the MCC group. Generally in the cohort, age was between 9 and 10 years, about 54–55% male, primarily PPO insurance type, and geographic mix with 34–35% coming out of the southern region. And on these, usually for standardized differences, we'd say if it's 0.1 or greater, we considered it unbalanced. As you can see on these, they're all pretty balanced. And you wouldn't expect there to be differences in insurance type or geographic region by the chronic condition profile a kid has. As far as the distribution of chronic conditions, this is the 10 most prevalent conditions that came up overall, and then I'll show you the SCC and the MCC cohort. Allergic rhinitis and asthma were up near the very top. That's in line with expectations from prior studies. ADHD was very high, it was about 19%. Then you have a sort of a set of other mental health conditions or diagnoses. Mood disorders is sort of a composite of depressive and bipolar disorders. Anxiety, developmental disorders are things like learning disabilities, congenital anomalies, autism and related, and then chronic ear infection. So then when you add in the two different cohorts, so the SCC and MCC, the top three conditions remain consistent. It's allergic rhinitis, asthma, ADHD. The prevalence is much higher in the MCC cohort, which makes sense. But the three conditions overall do drive a lot of this. It's when you get lower in the list that you start seeing some differences. So if you can see, I know the stars are a little bit small. In the SCC cohort, you see blindness and scoliosis and other sort of musculoskeletal deformity come up into the top 10. That does not appear in the MCC cohort. It's down closer to 1920. And then in the MCC cohort, you see the autism and related disorders are a much higher proportion of that group than of the SCC group. As far as the distribution of number of conditions, so this is looking within the MCC cohort. Minimum is 2, maximum was 27. Now this is highly, highly skewed. That's why the median's in here too. The mean was about 2.7 conditions. But as far as distribution, about 63% had 2 conditions only, 22% had 3, 8% had 4, and then about 7.4% had 5 or more chronic conditions. So about 40,000 kids. And then as far as the dyad, so among children who only had 2 conditions, which is the majority of this group, these are the top 10 dyads that show up, and they account for about 24% of the overall MCC population. Asthma, allergic rhinitis is number 1. Then there's a set of mental health comorbidity, which I think is something I have more in my discussion on that I think needs to be digested a little bit, whether these are distinct conditions or whether they represent sort of presentation of mental health symptoms that get diagnosed differently over time. It's for discussion, but at a minimum, they are coming into the healthcare system and utilizing the healthcare system with these different diagnoses. Organ system distribution, so a way of collapsing it at a bit of a higher level. So same sample size, this is my multi-morbidity cohort. The number of organ systems involved went from 1 to 14, mean of 1.9. 36%, 37% of kids had a single organ system involved. So this is the things like that mental health comorbidity would be a single organ system involvement. About 48% had 2 organ systems involved. 10% had 3, 5, 4.75% had 4 or more organ systems involved in the multi-morbidity. The most prevalent was mental, followed by respiratory, and then neuro, musculoskeletal, digestive, and so on. Now, starting to look at what these kids look like as far as their interaction with the healthcare system. There's a lot on this slide, so I'm going to walk through it bit by bit. General takeaway is MCC kids are higher utilizers than SCC kids. But it comes through in some very specific areas. So they have more outpatient office visits than so children with multi-morbidity have more outpatient office visits than children with a single condition. This is primarily driven by specialty care. They have higher utilization of specialty providers as opposed to primary care providers, as well as higher costs, about double, little less than double the cost occurred via specialty providers as opposed to primary care. The mean number of hospitalizations was also higher in the MCC group compared to the SCC group. And the prescription utilization in the MCC population was much higher. Now, presenting this as SCC, MCC, a lot of this is kind of common sense. They have more conditions, they're using the healthcare system more, they're being treated for more conditions, they have more pharmacy. Where this becomes, I think, a little more interesting is when you start looking at it by class and by profile of conditions. But this does help to characterize a group that we haven't really had characterized before. Looking at the pharmacy dispensings in a little bit more detail, this is annual rate of dispensings by drug per 1,000 population. ADHD drugs are just gangbusters in this group. So methylphenidate, then you see different antibiotics in here, amoxicillin, azithromycin. In the MCC group, you see the asthma medications as well, and then you start seeing things like sertraline popping in as well. And this is, so sertraline is 287 dispensings per 1,000 population annually. When you look at it by therapeutic class, again, stimulants are number one, but the rates, so in the SCC population, you would assume this is a child with ADHD only, or it would be 936 per 1,000 population. In the MCC group, it's about 1,500 per 1,000 population. High utilization of antidepressants. The adrenal combination was corticosteroids, glucocorticoids, anticonvulsants, antibiotics, and then other tranquilizers and antipsychotics as well. And then just to get an idea at the population level of what this looks like, outpatient visits. So the SCC cohort had about 1 million kids in it. They had about 888,000 outpatient visits in a year, compared to 546,000 kids in MCC and 524,000 outpatient visits. Emergency department utilization was higher in the MCC group than the SCC group. Inpatient hospitalization was higher, and prescription dispensing was higher. Same thing as far as the rate of encounters. So I don't have the p-values on there now, but yes, the comparisons are using non-parametric because it is highly skewed. I haven't investigated yet sort of dealing with the high outliers in this group. There, as we know with cost data, you have a couple of individuals who are just way up on the scale. The majority of them are much lower down. One of the things that we've discussed is sort of trimming the upper utilizers to get a better idea of the general population. I will say negative values were excluded from this. So if they had a claim with a negative value on it, we didn't count the claim in the calculation. And then cost at the population level. So this is $4.5 billion annually for children with chronic illness, and about 56% of that, or 2.6 billion annually, comes from the MCC population. A lot of this is driven by inpatient and pharmacy costs. So pharmacy is 40% and 30% for inpatient. Outpatient costs as a proportion of total costs are lower in the MCC group than they are in the SCC group. And then as far as the distribution of outpatient costs by visits to primary care providers versus specialty providers, you can see a higher proportion of the spend in MCC comes from specialty providers. So that's sort of a big picture look at kids with a single chronic condition versus kids with 2 or more. The work in progress right now is, one, the cancer survivor subcohort analysis. I'm not presenting the details on that today. I can say the condition distribution among those kids is substantially different than the general pediatric multi-morbidity population. Much higher prevalence of central nervous system disorders, neuropathies, things like that, which is expected given sort of the effects of cancer therapy, but you still see high rates of mental health diagnosis, things like that. What I am going to show a little bit of the work in progress on is the latent class analysis. So going into this, conventional wisdom on latent class analysis says you put no more than 15 indicator variables into a model, otherwise your model starts getting unstable. And what I found is when you have 550,000 people in your cohort, you can put more than 15 indicators in your model. But it's taken some time to develop those because learning what the models can handle as far as number of indicators versus population size has been a bit of a learning curve. I will show a preview of the clusters that are appearing consistently and some of their characteristics. The next step is to do some of the modeling work around this and try and do some of the adjustments. I may not have made it explicit previously. These are unadjusted estimates that were shown in the earlier slides. So this is the latent class analysis model. It's using the indicators with 2% prevalence or more. It has, I think, 22 or 23 indicator variables. And this is sorted by prevalence. So you'll see allergic rhinitis, asthma, ADHD, mood disorders, anxiety disorders, also congenital anomalies, encephalopathies, allergy, menstrual disorder, hearing loss and blindness, some of those less common MCC, more common SCC conditions, and so on. So what we've currently landed on is a 7-class model. The way that this is laid out here, you don't pre-specify who the people in your model are going to be. You let the data sort of drive that and classify them based on their characteristics. What is highlighted here are in the lightest yellow color, which is a little hard to see on the screen. It's whether they had if somebody in that class had a probability of having that indicator of 20% or greater. In the orange is if person in that class had a probability of having that indicator 50% or greater. And then if everybody in that class had an indicator, if it's 100% probability, that's in the dark blue. Generally, when interpreting these models, you characterize the model based on indicators of 0.5 or higher. I hypothesize, we're still looking at this, but I hypothesize it's a little different here because there's so many indicators. Some of these don't have the 0.5, but they have a 0.3, a 0.4. That still is probably informative around who's in that class. That's sort of justified by looking at the conditions of the kids in those classes. So based on that, and based on the predicted probabilities of class membership, we seem to have 7 classes, and these are consistent across specifications. If you use 1% prevalence, 2% prevalence, 6-class model, 8-class model, these 7 classes seem to appear consistently. So there's chronic otitis media and sort of other ear, nose, and throat. Class 2, which doesn't have as clear a signal as others, but seems to be developmental disorders. That's with autism and related disorders, developmental disorders, and then you see upticks on epilepsy and encephalopathies and other nervous disorders. Class 3 is a mental health cluster that seems to be mood disorder centered. Class 4 is allergic rhinitis and asthma exclusively, which, if you'll recall, that was the highest contribution to the kids who had 2 conditions only, so that's a pretty clear group in and of themselves. Group 5 is unclassified, sort of a series of conditions, none of which put them in one category or the other more clearly. Group 6 is another mental health cluster that's ADHD centered. And then group 7 is another allergic rhinitis asthma cluster, but now with sort of other comorbidity mixed in as well. As far as, we were curious who is unclassified, who's falling into that class 5 that didn't have a clear sort of mark on it. It's a mix. They have the common conditions like asthma and so on. They have some of the congenital anomalies. This is a group that has a relatively high prevalence of menstrual disorder compared to other classes, which will show up when you look at the demographic characteristics of that class. But regardless of which LCA model specification, which way we run it, we always end up with an unclassified group. There's just a group of kids who don't sort cleanly into one of the other classes. So that is probably just going to be an artifact of the analysis and something we'll look at. So what do these kids look like? So here's class 1 through class 7. Ages differ. I'm not showing statistics here because I haven't done inferential or sort of hypothesis testing comparisons on this yet. It's just intended to show what this looks like and what the differences might be between the groups. Mean age varies significantly. The highest age is in class 3, which is the mental health mood disordered centered group. Gender varies. Again, I mentioned that class 5 is sort of the lowest proportion of male. That's the group that has the higher prevalence of sort of menstrual disorders. Hospitalization rates vary, ED rates vary. Highest emergency department utilization is in class 3, which is this mental health mood disordered class. Interestingly, and something we've had come up in discussion, is they also have the lowest outpatient visit rate. So it makes you wonder, are they sort of shuttling into the ED setting and not being seen or managed as closely in the outpatient setting? As far as outpatient visits, the group 1 and group 2 are pretty similar. Again, I don't want to sort of overstate the similarities or differences here, but Hospitalization rates, ED visit rates, prescription dispensing varies quite a bit amongst these groups. One thing, again, that came up in discussion is if you look at group 4 and group 7, which are the allergic rhinitis asthma groups, you would expect asthma medications, they have their controller medication, sort of their emergency medication. This is prescription dispensings annually on average. If it's an asthma group and they have 10.6 prescription dispensings annually, even if those are all their asthma medications, are they being adequately controlled? Would you expect 1 prescription a month, in which case the average should be 12? So there's still some additional investigation that can happen in these groups. And then finally, looking at prescription classes. Group 3, the mental health mood disorder, and group 7, allergic rhinitis asthma with other comorbidity, sort of had the most number of distinct classes of medications that they were on in a year. So, discussion. Just in summary, of children with a chronic condition in this commercially insured cohort, so let me take a step back. In the cohort, 25% of kids had at least 1 chronic illness diagnosis. And of those 25% of kids, 65% had a single condition, but about 35% had 2 or more. So it's a substantial proportion of the pediatric population. There were no differences in baseline demographics between children with multiple chronic conditions and a single chronic condition. As far as the distribution of conditions, asthma, allergic rhinitis, and ADHD were the 3 most prevalent overall and by cohort, although the prevalence of each of those conditions were different and sometimes double in the MCC cohort than they were in the SCC cohort. And among kids with MCC, the combination of asthma and allergic rhinitis alone and in combination are key drivers. And this is a little bit reassuring. In comparing it to the Clark Medicaid analysis, they had the same finding. So even though they excluded mental health, even though it was Medicaid versus commercial, some of this seems to replicate and have some consistency. And there was a high prevalence of mental health conditions. It was the most commonly involved organ system and of mental health comorbidity. As far as utilization, $4.6 billion annually. This is 2017 US dollars. Differences primarily driven by inpatient and prescription costs. MCC is just a higher cost, higher utilization population. More drugs, more classes, higher costs, and so on. MCC population had an 8% lower continuity of care than the SCC population. This was dispersion across the different types of providers that they might see in a year. And then there appear to be significant and meaningful differences in the measures of utilization by morbidity cluster. Again, haven't done the sort of statistical hypothesis testing on it, but there do appear to be differences. As far as considerations for interpretation, I mentioned already statistical significance is minimally informative here. Sort of more absolute differences, standardized differences, give you a better idea of the actual group comparisons. The utilization that I presented are crude estimates. It characterizes the breadth of the problem, but further exploration is needed. That's great because those are my other dissertation aims. And then mental health diagnoses. I personally was surprised at seeing the prevalence of mental health diagnosis, but I think it requires consideration of, are these distinct conditions? Are they a reflection of the diagnostic process? Are they physicians getting it wrong, coding one thing, coding another thing, and it's showing up as multi-morbidity? My sort of the way that I hope this analysis will help in terms of interpretation is through the cluster analysis, where you get that sort of mood-based cluster and you get that ADHD-based cluster, that maybe that helps to take care of some of that diagnostic-based imprecision. As far as limitations, one thing here is it's difficult to generalize national population level prevalence from this study for a couple of reasons. One, the continuous enrollment criteria is going to have some selection bias associated with it. Kids who are sicker might have parents who are more likely to stay continuously enrolled, so the prevalence might be higher in a continuously enrolled group than in just a general population cohort. Also, there's a high likelihood of undercoding in ICD-9 codes of key pediatric chronic conditions. The one that you immediately think of is obesity, that's kind of notoriously undercoded. But also mental health conditions. It's sort of a tension here. I have high mental health diagnosis prevalence, but also, children require a certain level of severity and a certain type of interaction with their family to get in and get a diagnosis in the healthcare system. There's potential for misclassification in the chronic illness. I'm using a sort of generalized algorithm for morbidity and chronic illness, this AHRQ modification for pediatrics. There are benefits of using that. It's generalizable. It's been used in other sample populations. I can make easy comparisons, but it may not have the precision that an asthma-specific sort of diagnostic criteria or an ADHD-specific diagnostic criteria might. So something to keep in mind. And then claims data lacks really important socio-environmental variables that may be associated both with the conditions that children are diagnosed with and the outcomes that I'm measuring, such as cost and quality. That's sort of a notorious limitation. It has to be acknowledged, but hopefully, further work can take this on and explore that in more detail. Implications and next steps. This was the first study to characterize the extent of MCC in a national commercially insured population, and the first that included mental health diagnoses as one of the characteristics of pediatric chronic illness. And then one of the sort of takeaways for me as I progress onto my additional aims in my dissertation is that asthma and ADHD and some of the other really common pediatric conditions that I see in my cohort are also key targets of quality measurement in pediatrics. So I should be able to get some robust measurement and really look at these in more detail when I get into aims 2 and 3, looking at quality outcomes. And thank you. I'm happy to take questions or suggestions. That's Coco. Ernest.
Could you go back to the slide where you looked at the differences in utilization costs? Great job, by the way.
Yep.
Really nice work.
This one?
Yeah. Have you looked at just histograms of perhaps some of those means? Because what struck me is that they're very similar, mostly similar across the classes.
Mm-hmm.
But is it possible that there's a difference between costs in terms of the proportion of individuals that contribute to that number of hospitalizations? So maybe for some clusters, there's a smaller group that explains that versus others that there's more even distribution.
Yeah, I haven't looked at the full distribution. I say I've sort of done it by categorical groups of number of. Outpatient is a little tricky to do because part of my cohort entry criteria in the baseline is utilization of outpatient services to get the diagnosis. So there's a little bit of, on outpatient counts, it might be a little bit less informative, but for inpatient and ED, certainly that's something to look at.
Yeah, because otherwise, just looking at this table, it doesn't seem like there's much differentiation.
Yeah, and that's to Dr. Crawford's point as well. This is sort of necessitates skewed data methods. So that's why this is sort of an in progress, just snapshot of what it looks like. Yep.
Rachel, has this been done in adult related class analysis?
Yep.
So you didn't have any hypotheses that you included in this presentation. Usually in a dissertation, it's driven by frameworks, testing hypotheses. Did you think about some hypotheses that would potentially be included in this paper?
So
is that part of your other papers too?
I have explicit hypotheses in aims 2, 3, and 4. I've had some discussion with Todd, and one of the things I'm hoping to take back to my committee is actually to combine aims 1 and 4 so that the descriptive work and the hypothesis testing work on the utilization and cost side are combined into the same paper. So it would be one paper for a general cohort, one paper for the cancer cohort, in which this analysis that I presented it for the general overall pediatric population. The same analysis and clustering is being replicated among children with who are early survivors of pediatric cancer.
I mean, an obvious thing is to test like the hypothesis that would or would not be different than the clusters identified.
That's aim 4.
Did you look at the prevalence of the chronic conditions in the children prior to exposure? So when you had it started at 25 million, and you went down to 5-ish. million. Because I'm wondering, there's certain conditions where you automatically qualify for Medicaid.
Mhm.
And I'm wondering if one of the reasons they didn't have sufficient enrollment time is because they fell out of the commercial insurance right into Medicaid.
Because they qualified.
And several of those conditions are they're significant conditions.
Yeah.
So in adults, end-stage renal disease, for example, you automatically qualify for Medicare. And I think there's certain things you can qualify for Medicaid for. You can actually be dual as adults in Medicare and Medicaid. I forget what some of those conditions are, but.
Yeah. I hadn't looked at it generally in the excluded part of the cohort. I do have a sensitivity analysis that cuts the continuous enrollment down to 2, so it measures their chronic conditions in 1 year and their outcomes in the next year. I don't want to misspeak on the numbers because I don't have them off the top of my head, but I haven't thought of that. That's a good point.
I mean, it'd be really shocked. I mean, it would be intriguing if you had some of these diagnoses and then shortly after that they no longer were enrolled.
Oh, okay.
Because that would be, especially with developmental disabilities, and I don't know if it would be in the scoliosis or some of those, but it's really severe epilepsy.
Mhm.
For
Okay.
children.
Disenrollment. Okay.
I was just curious, Rachel, did I see psychotherapy up there?
I think you might have seen that in the medications. It's like psychotherapeutics.
Okay.
It's psychotherapy, tranquilizers, antipsychotics. So it's a
wasn't like talking psychotherapy.
no. This is
Okay,
based
thank
on
you.
the indices of the drugs that they
I
receive.
didn't think that made sense, but I thought so.
Yeah.
Thank you.
Ernest?
I'm just curious about that unclassified group. I know you said you wanted to restrict your analysis to be classified, but if you continue to increase classes, does that unclassified prevalence get kind of cut down?
Not really, no. And what happens is the model stops converging. So I start having to run it with, instead of 600 starts, I have to run it with 800 or 1,000 starts, and it still doesn't, maximum likelihood, so you need it to hit the same maximum multiple times to sort of converge on the best model fit. And what happens is that I don't hit that same maximum likelihood multiple times. It only will happen once. So a way of simplifying that is saying it's stretching the data too thin at that point. That group, that unclassified group though, so at first I thought maybe the 2% prevalence indicators weren't enough to substantially classify that group. So we reran it with the 1% prevalence indicators, which covers 99.3% of the population have one of those conditions, and you still end up with 13 to 15% unclassified. So it's just whatever spectrum that they have just doesn't fit a pattern that otherwise sorts out in the data. Yeah.
I'm wondering if these conditions are equal. Like, so if you have a multiple chronic condition, is that really worse in reality for some of these than if you have one of the single conditions?
So I think that's a complicated question. It could be that they're getting the care from the same provider, right? So if it's in the same body organ system, if it's 2 mental health conditions, or if it's asthma, allergic rhinitis, is that really much more severe than another? I think the reason that I pursued the construct of MCC as opposed to something more disease specific or severity based is because in the adult literature it's been so clearly shown that just the number of conditions has this impact on outcomes and quality. And there wasn't really a sort of similar or analogous study in the pediatric population. But I think that that's a point for discussion and further sort of examination is, when you look at these condition pairs or you look at the condition sets, and I don't have severity in here. I mean, that's, sort of another thing that, if you have really severe asthma and allergic rhinitis, is it different than if you have well-controlled asthma and allergic rhinitis? So, yep.
I think you just hit on something that's really important that we talk about on the clinical side with kids versus adults.
Mm-hmm.
So kids aren't just little adults.
Yeah.
So I think when you ask that question of if you have asthma and allergic rhinitis, how much worse is it?
Mm-hmm.
As adults, we can separate it. But for a kid, how they deal with it, they're not early.
Yeah.
So it really resonated with me when we did the
Mm-hmm.
approach. you're kind of all the same thing.
Yeah.
When you're playing with playground, it's hard. You know, as your nose stops up and you can't breathe, it doesn't matter. You're still playing.
So I think, further exploration of sort of the comparison and the combination of body organ system might be useful there. For the cluster analysis, I wanted to leave it the individual conditions because I think if you group it at body organ system, you lose some of the nuance of that. But we can, explore the dyads and body organ system and sort of dyads and triads, I guess, and comparisons there.